welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD's CEO, Dr. Joshua Liu. Today we're joined by the awesome Dr. Mike Ross, System Chief Medical Information Officer at Optum, supporting Northern Light Health in Maine. Dr. Ross, Mike, welcome to the show.
Thank you so much for having me.
Well, it is absolutely our pleasure to have you on the show today. You've had just such a fascinating career. Initially, you were interested in psychology, and then you found your way into pediatrics, and then augmented your clinical care with more technology-focused roles. So to start the conversation, I was really curious, why pediatrics to begin with?
Yeah, I asked myself that a lot, especially during residency. I really had no intention of going into peds initially. What I wanted to do is I wanted to go into a field where I felt like I could make a difference, and I wasn't just kind of prolonging misery or prolonging kind of the current care. And so internal med was pretty much immediately out. ED, it wasn't that connection with the patient over a long term that I wanted to do. Surgery was too cut and dry, no pun intended. As I got more and more involved in peds, I found myself more drawn to primary care. Initially, I had pretty strong intentions of going into ped subspecialty, but the birth of my first son happened right at the beginning of residency, and that really influenced me towards primary care.
It's awesome. And then at some point, you were obviously bit by the technology bug, as we call it. How did that happen?
Looking back, it was always there. It needed to come out. It needed just an opportunity to evolve. Whether that was in the way that I studied for things, utilizing, massive review sheets that I would type out. And then in residency, I found that I relied really heavily on my PalmPilot. Everybody remembers those. I had the peripheral brain and High Note. Still remember the app. High Note had everything all organized, all my different categories. And in my second year, I began to wonder if I could actually start typing up my notes instead of writing them on the wards. They were laser printers, and they all had little laser IR port. And so I picked up an adapter and one of those little foldable keyboards, and started typing up some of my progress notes. It was awesome because the attendings would read my notes because they were legible and they were detailed. And so I kind of got a reputation for having both content that was there and was readable. And that just kind of opened my eyes to the importance of documentation and how legible documentation really was able to kind of concisely show that patient story was so important as part of the chart. I mean, I shudder about how un-HIPAA it was at that time, but that was before the days of HIPAA, and wouldn't be something that we would do now, but that's why we have the EMR as its repository.
Mike, can I ask you, so you've lived through, I guess, the first phase of going from written notes to typing notes, and now we're going to this new phase of from typing notes to, let's call it, voice notes through Ambient and Scribes. Yeah. And I'm curious, looking back, do you feel like we lost anything about medicine going from writing to typing notes? And then also, do you worry about us losing anything as we go from typing to voice?
Oh, I'm totally going to pull the back in my day card right here. I don't think we lost anything going from writing to typing. I felt like my notes were, and others' notes were, for the most part, better. I do worry about cut and paste. I think everybody does. I do worry quite a bit about what's going to happen with AI if we start giving AI tech to our students. I mean, we learn so much by writing it down, by developing a plan, by coordinating ourselves. I mean, that's that active brain engagement. And so I am pretty concerned about that. The other thing that I'm a little concerned about was, what happens when we lose all this? We've all had downtimes. We had a yucky, nasty breach a bunch of months ago as becoming more and more common. And we had to go around and show some folks how to write paper prescriptions. So it really is becoming a lost art. For all those reasons, I think that there's dangers in losing it, but I think it's the right direction and the progress of technology moving us forward.
So I guess in some sense, when you think about where medical training needs to be, I don't know how they're going to fit it, but it's almost like you kind of want trainees learning how to write notes, even if you don't expect them to necessarily use that day to day. It's almost like you want to have some sort of fail safe when stuff does go down, because apparently it does.
Yeah, absolutely. We actually had a conversation about this just a couple of days ago as we're rolling out AI-based scribes and what we're going to do with our residency. So what we're leaning towards is the first couple of years, we won't offer AI scribes to our residents. And then starting in third year for FP residents, we may lean more towards use of an AI scribe. But I mean, if I was coming into a program and there was a tool that would reduce my workload and I was comfortable with the learning development that I was getting, and I was staying in the wards working on notes for no reason other than just to fulfill an arbitrary time of 2 years, that would frustrate me. So I think there's different ways of looking at it. So I'm not going to commit to it, but I think that it's an important skill that we not remove from our upcoming future doctors.
Because, the analogy it makes me think of is, like, if you think about driving, right? Like, I used to think that, I don't know, maybe like 10, 15 years from now, when most cars are potentially autonomous, future generations may not even get a driver's license, may never have to learn to drive a vehicle. But then if something goes down, you're going to kind of wish the person could, handle the wheel. And so I actually am now rethinking, like, maybe everyone still will have to learn to drive just in case. Yeah. I don't know. We'll see.
Yeah, so absolutely. And I've got a 19-year-old and a 22-year-old, and both of them, they don't know the area that we live in like I do, because they just plug it into Google Maps every time they go anywhere. And that's kind of an example of the reliance on technology. Does that make it, bad that Max and Alex don't know their way around Bangor, Maine? I don't know, but there certainly is different.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
Huh. But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Huh. Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more. So, Mike, I wanted to ask, Northern Light Health recently received the HIMSS Davies Award under your leadership. So first of all, congratulations on that. That was for rolling out a system-wide implementation of Oracle Cerner. I'm curious, were there any challenges or key successes other than just the implementation itself for the rollout? It's such a massive undertaking. I'd love to get your perspective on it.
It was a lot of work, and thank you so much. I'd be remiss not to acknowledge the work of and the partnership of my fellow leaders who work so hard, other CMIOs, my CNIO partners and dyads, our administrative dyads, and the leadership of April Giard, who leads Informatics, as well as a lot of our technology. I'd say that in terms of challenges, it was demonstrating kind of just the depth and the breadth of the challenges within Maine and how those challenges need to be overcome. Maine is a massive state. You can fit all of New England into Maine and have plenty of room left over. And trying to work with folks that are, hours and hours away and all have on the same platform, all have on the same education, And being able to work that across a system was a considerable hurdle. We really focused on 3 areas for Davies. We focused on alert revisions. We went through our drug and drugology and dose range checking and significantly cleaned it up and demonstrated our work with care management associated with our cardiology heart failure patients and the role of technology that plays there. And then, like everyone else, we got hit hard by COVID, and trying to develop a response across the state in a newly untested mass vaccination program and mass swab program was quite the undertaking. So that's really, those were the cases that we focused on. And we were thrilled to win the Davies. It's our second Davies. My predecessor and mentor, Dr. Eric Hartz, who was a CMIO many years ago, I watched him get the Davies Award in 2007. And it was always a professional goal and a professional dream of mine to do the same. So it was very meaningful.
Can I ask you, like, if you're able to give yourself advice when you just became CMIO, what's the number one thing you would have told yourself before starting that role?
Oh, I would have told myself to thicken that skin. Peds has done such a nice job of prepping me for CMIO. There's so many things about Peds that make pediatricians good CMIOs. You know, we're team-based, we're patient-focused. We have this kind of underlying philosophy of children do good if they can. You know, that no child gets up in the morning and says, I'm going to throw a bunch of tantrums today. And doctors and other professionals do the same. Nobody gets up and says, I'm going to lose myself at the EMR. And so having that appreciation of where my colleagues were coming from with frustrations has been really helpful. But sometimes those frustrations can boil over, and it's been a well-worn thickening of the skin. I've had some great mentors, good friends in cardiology and in surgery and in leadership who have taught me how to understand the difference between frustration and venting and constructive criticism. So if I could look back, that's what I would probably tell the 2016-year-old version of me.
In some ways, I guess when folks do express frustration or they vent, I guess the positive is that at least you're getting some engagement, as opposed to folks who are dissatisfied but don't tell you what's not working, and then you don't learn anything from it.
Totally. I mean, give me a 4-year-old who's having a tantrum over the moody teenager who goes up to their room and closes the door any day. So if somebody's sharing their frustration, once you kind of bring down that emotion, you can begin to work on it. When people are not engaged and not involved, that's when you have trouble. And we've really gone through some significant changes in that with our culture at Northern Light. We went from lots of different EMRs, Centricity, all scripts, niche EMRs all over the place, to a consolidated whole. And we heard it all. You know, we heard all the good, all the negative. It's really not about the vendor. It's about how you bring stakeholders together into governance, how you get that collaborative discussion going, and how you just kind of work towards making the workflow for the patient work out best.
Can I see on that topic? 'Cause I think one of the things that I've learned to believe is that, and I think you'd probably agree, it's not just the technology, it's the people and the process too to make digital transformation work. But I'm curious, how much of that success can come from the vendor side? Like, what's your experience around, hey, actually the best vendor was maybe the one that didn't have the best tech, but had the best people and process? I'm kind of curious, like, what vendors can do better given your experience.
Yeah, absolutely. It's a 3-legged stool. And I would say that I would agree 100% that people and that process, that makes the biggest difference. We have really, really enjoyed our work with Cerner, and we're looking to Oracle Health as they've taken on looking to develop and may perhaps go back a little bit to some of that Cerner relationship building. They do a really nice job of an embedded team that we had here at Northern Light. We had a long-term relationship with them, and we're looking to see that kind of relationship continue, because it is about, perhaps you don't have the leading tech or the best tech, although you have quite a bit of it, but it's being able to call on those resources and get that support and connect with other clients who have utilized the software in order to understand and craft a response where things get most effective.
Earlier, Mike, you were talking a bit about Ambient and Scribes. So are you in the process of rolling out the new digital assistant? I'm curious, what's going on there and any learning so far?
Yeah, absolutely. I would say that is a huge part of what I'm doing right now. We are really focused on bringing AI scribing to our providers. We want and need to balance the financial costs of that against the benefits. We've seen the benefits, though, whether that is on volume or on reduction in burnout. It's not for everybody, and I hope we'll talk a little bit about who it is and who it isn't for. But for those that it seems to be for more people than it's not for. And for those where it works, it seems to make a profound difference. And we're looking at a couple different options. The Oracle Health Clinical Digital Assistant is a really nice tool and integrates beautifully with Cerner. We're looking at that as well as some offerings from Nuance as well. Both have their significant advantages.
Yeah, well, Mike, on that point, I noticed years ago while you were at Eastern Maine Medical Center, you actually were an early adopter of ambient technology. This was way back in the day of like Google Glass with technology like Informatics. So I'm curious, could you tell us more about maybe the profile of clinician that this technology seems to lend itself well to versus ones that maybe aren't the quickest to adopt it or don't need to even?
Yeah, Augmetics is a fantastic company and had a really strong relationship with them for quite some time. I brought Augmetics to Northern Light, starting with Eastern Maine Medical Center as a 5-person pilot in 2016, and found very quickly that those who were flexible and could incorporate a team member and also were able to cede some degree of control were the ones who adopted things like external scribes and now moving forward into AI-based scribing. Those are really the folks who thrive with that. Those who have to own every aspect of the documentation, it's not a good match for. In fact, it can actually go backwards because what you find is that whatever the offsite scribe or the AI scribe would put onto the page, you'd see some providers would go back and change that. That's not a good match. So there has to be a certain degree of flexibility. And most folks will say, yeah, I'm my own worst enemy. I'll go back and change stuff because there isn't a huge difference at the end of the day when we talk about what's on the page. What we're looking for is that big picture message. And one sentence here and one sentence there does not an elegant note make.
How do you screen for that in terms of figure out who is willing to give up more control or who needs to maybe own everything? Like, is it simply you let them try it and then you see how much time they spend editing it, or is there a way to screen for the right clinician?
That is such a good question. And I think that we're starting to get a sense of that. I find that if I ask those around that clinician, the style of that clinician, I can get a good sense of how things are going to go. So if I talk to somebody, I hear from practice manager, I've got a provider who is a significant amount of after hours time, and we confirm that with our analytics on lights on and within Oracle Health. And then I then go and round with that provider in clinic, and I talk to the MA, and I talk to the front desk, and I talk to the practice manager. And if the story I get is, the provider is redocumenting what the MA asked, and the provider is redocumenting the lab results, I get it. I understand where that comes from. I mean, I really do, of wanting to own that patient, and so you could have everything on the page that you are comfortable with. But there has to be an engagement with the team, and having somebody physically get to the act of writing that for you, that's a real indicator of success. So I've started to get a sense of this may or may not be a good person for different solutions.
That makes sense. And you mentioned earlier that it sounds like you may be trying more than one solution to see like what might be the better fit. Like, is the idea that you're going to try more than one thing and then decide on something for the system? Is it more that you're trying to figure out maybe there's one solution that's a better fit for certain specialties versus others? And then also, like, how do you think about how to properly do that comparison? Like, is it totally like an RCT internally? Is it a different way of doing it?
Yeah, I think that the answer is yes to all of those questions. We're looking at it on a specialty level versus a primary level. We're looking at on a degree of integration versus outboard associated with it. One of the things that one of my partners, Emily Burden, has really brought is a intense focus on analytics. We work very closely with Oracle Health in terms of not just the internal lights on review, but also some customized reports that we work on with Oracle Health that allows us some pretty deep insight into how our providers work. So we gather a ton of data and then review post-implementation that content. And that really helps guide us in terms of which direction we're going in with products, with adoption. Do we need to loop back around with some additional classes, things like that?
That's awesome. So, Mike, in addition to AI virtual scribes, obviously AI is kind of permeating all aspects of the EMR. I'm curious, what do you believe today, maybe aside from AI virtual scribes, is kind of the lowest hanging, highest ROI use case for AI? And then on the flip side, what do you think is maybe overhyped today?
I think that some of the radiology stuff, and then if you take that, you apply it to dermatology, you apply it to imaging, that holds tremendous promise. Some of the population slicing and dicing associated with AI holds tremendous promise. Some of the patient engagement, patient-directed stuff, I am struggling with a little bit.
Yeah.
I think chatbots have their role, but every time I talk to a chatbot, I know pretty soon that it's a bot. Either that or I think I do. And my mom's dealing with some health stuff recently and some pretty serious health stuff, unfortunately. And she's had some experiences with chatbots, and her reaction almost immediately is, get me to a human. And so I understand their role. I certainly understand their role in e-commerce and retail. I'm just not yet convinced that is fully applicable to healthcare.
Yeah.
I really like the use of chatbots supplementing a person. The idea of somebody else being there and the chatbot whispering in their ear, hey, this patient is calling from here to do this. But I don't know. I gotta just that, person working with the AI face front yet, patient rather working with the AI face front yet. I'm still waiting to be convinced.
Yeah.
It's funny because you're the idea that you're getting as the perfect co-pilot with AI, and it makes me think about when I think about how even I'm just using ChatGPT sometimes at work or even for personal. I'm using it as a co-pilot. I'm asking it questions. I'm getting it to challenge my thinking. I'm getting it to maybe improve, the grammar or something. But I'm using it as a co-pilot, really, not as an autonomous chatbot for a certain use case as a consumer.
Right.
And so because I have the right context, I know the right questions to ask. I'll give you an example, right? Let's say my wife is asking me a question. I'm like, I don't know the answer totally, but let me query ChatGPT and ask follow-up questions. I think in the same way to your point, it's like you can imagine a clinician where it's interacting with the AI to make sure it's getting the full context or some of the data, but it's still the clinician interacting with the patient to put all of that in context and to communicate it clearly and get to the right, answer with the patient. So it kind of reminds me of that. It's like, that's the first step. But you're right. I the other day I was looking at some car insurance stuff, and but this is a major insurance company, so I'm sure they could, afford and implement the latest and greatest kind of chatbots. But it was terrible, and I just asked for an agent in the chat, and then I got an agent, and it was much better. And I'm pretty sure they were probably using a co-pilot to answer a lot of my questions.
Yes, exactly, and I think that's a perfect analogy. It can make things more efficient and effective. It can offload some duties like documentation or patient visit summaries or clinical justification. All those things can be offloaded to it. But to have it as the new face, let me help you navigate initially, that's a tough one. People see through it, and it can set things off negatively. I mean, my mom's basically ready to, when she was talking in this thing, was ready to kind of throw it. And like you said, just immediately press 0, get me to an operator. So,
yeah. So Mike, actually, we had the privilege of seeing you at HIMSS earlier this year. And in your presentation, you were talking about the critical role of asynchronous digital care in telehealth and how it improves access to care, especially in rural and aging populations. So I was curious, how do you see the future? I know you're not immediately working on telehealth yourself anymore, but I'm curious in your system, what do you think is the future of telehealth, especially regarding asynchronous care, and how we can maybe integrate this into healthcare in the future?
Yeah, absolutely. So I had been very heavily involved in telehealth. I've moved away from that a little bit, but still have a passion for it and interest in it. and especially that of asynchronous. I mean, just the idea that in just about any other field, I can send off an email or, hey, what do you think about this situation? What do you think about this case? What do you think about that? And there's even infrastructure associated with being able to document and bill that. Yet in medicine, it's got to be a curbside. It's got to be, you have to take that hit as a provider for the good of your patient in order to help reduce your patient's need to go X number of hours travel, to sit in a waiting room, to be seen by a specialist who might just say, you're fine. A slight degree of compensation, email somebody saying, hey, I've got this patient with this. What are your thoughts? And, we have that now. They're called eConsults, and they've rolled out and they've been, I would say, moderately successful. We found that they're very useful in specialties that are very much results-based. So hematology, rheumatology, review those stuff with me. Not so, in GI or cardiology, but that has really helped us across the system in terms of being able to bridge some of the digital divides. What I'm really looking forward to, and if we start thinking about, where does AI plug into these things? I mean, imagine that I want to send off a eConsult. And so I document my note and I then ask AI, okay, please summarize this for the rheumatologist because I want to send off an eConsult. I mean, that is the kind of thing that would be so helpful because right now we have providers, again, taking that hit. They're summarizing that for the rheumatologist as opposed to having somebody else offload that. It won't be perfect, but it would be a huge step forward. And those are the kind of advancements that I see AI being able to bring forward.
And just to understand, Mike, when you say summarize the note, is that like summarizing the patient's entire history so that they have like an executive summary at the top of the referral, or what does that mean in this example?
Yeah, it's exactly like you said. So one of the ways that we have implemented our eConsult program is we have asked our primary care providers to, give a quick blurb, why, what's the crucial question, what's the critical question they're asking, and what's the supporting documentation. And that puts a decent amount of emphasis upon the PCP. We do reinforce that the specialist should be looking up those results and reviewing the chart in detail to get more of that content. But to help both of those, both the primary care provider as well as the subspecialist be able to synthesize that information from the chart, that's really where AI could play a role.
And do you find that right now, like potentially the work that would be required to do that referral request is almost like added friction where a PCP just might be like, that's too much work. You know what? Like, forget the eConsult. I'll just try to figure this out myself or do something else. And maybe this will lower the bar, make it easier for folks to do an eConsult.
That's exactly it. That's exactly where I see things going. And I think that right now it's that ask of the PCP that is the barrier. It's a little bit lower than me calling up the rheumatologist for the curbside, but not much. And the compensation associated with it is still, still nickels. And I don't think anyone's doing an eConsult in order for the compensation, but it does help justify to some degree the RVU, the effort associated with it.
Makes a lot of sense. So Mike, last question that I had, with your extensive experience with informatics and telehealth and AI virtual scribes, I'm curious, what advice would you give to other healthcare professionals who are maybe looking to enhance their skills and knowledge in these increasingly, essential areas?
Absolutely. So the first bit of advice, and I think that this is pretty universal for our field, is to get educated. When you become a super user in an EMR, you are a super user in an EMR. And there are some strong informatic principles that really need to be followed. So it's getting that baseline education. You may not need to go as far as doing board certification, but at least taking a 10 by 10 or doing additional content. And then understanding that the importance of flexibility, the importance of teamwork and balance, and always approaching it from my mentor, Eric Hart's, called WIFM, what's in it for me. Good. We never want to say, okay, here is informatics and we are rolling out this and this is now what you shall do. It's how does this change benefit you? otherwise folks just don't adopt. And that's what we found has really driven a lot of our adoption classes, our adoption focus, and our adoption work.
Yeah, I love it. With them. That's great. Awesome. Well, Mike, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. So just 5 rapid fire questions for you.
Okay.
I wish we had more time. Honestly, we could talk to you for another 4 hours. First question that we have of the lightning round: what is your favorite book or book you've gifted the most?
I would have to say The Martian. I really enjoy both the humor associated with Mark Watney's predicament, the focus on science, and then the focus on self-reliance. I'm going to find a way out of this. And a lot of that ties into how we as CMIOs need to work. We don't always have the answer. We tend to have, just like Mark Watney had NASA, we tend to have a huge structure behind us that supports us. We need to be kind of the face of that expertise and do so with focused intensity, humor, and joy.
Love it. Yeah. Question 2, who is a person either dead or alive who you'd love to meet?
I've been a musician for quite some time. I grew up playing cello. I switched to bass, electric and acoustic bass when I was a teenager. And my favorite band was Rush, still is. And so Neil Peart died a bunch of years ago. I'd love to have met Neil. I would say that if I could meet anybody now, it'd be Dave Grohl. He's just the voice of Generation X and probably just the coolest guy imaginable.
Yeah, awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I would not want to see what's in a lot of people's minds.
Yeah.
So definitely not that one. I would say super speed. I would love to be able to bang through my to-do list a little bit faster and be able to have a little bit more time at home with my family.
Love it. Question 4, what is something in healthcare you believe that others might find insane?
I would say just our ongoing ability to, with the best of intentions, unfortunately, sometimes shoot ourselves in the foot. You take so many examples. Let's share more information on the portal. Sounds like a great idea, but then let's let people find out they have cancer over a portal. And, let's do all these home COVID swabs. And what a great idea, but let's not do the same thing with strep and with influenza or with STD testing. I mean, there's so many options for that whole trend to continue forward, yet we take one step forward, but we don't always continue to step forward.
Yeah, great point. Last question, if you could travel back in time to any event or moment, what would it be and why?
July 13th, 1985, Live Aid, watching Queen perform. Nothing better. I would love to have seen Freddie Mercury.
Yeah, that would have been awesome. Well, thank you, Mike, for coming on the show today. That is unfortunately a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and want to learn more, visit www.seamless.md. Mike, Dr. Ross, again, thank you so much for blessing our audience today and coming on the show and sharing some of your wisdom.
Thank you so much for having me. Appreciate it.